My name is Alison Marshall. I'm a senior lecturer at the Kirby Institute and the Center for Social Research and Health. I would like to begin by acknowledging the traditional custodians of the land on which we gather today and pay my respects to the elders past and present. Today we are presenting from Bidjigal people of the Eora Nation. I extend that respect to Aboriginal and Torres Strait Islander peoples joining us here today in the audience and online. I think most of us are familiar with the format, but for those who are new to the Kirby Institute seminar series, the format will be a seminar followed by a presentation of question and answer. You can ask questions throughout, though, by clicking on the Q&A icon at the bottom of the screen. And now I'm going to introduce our international speaker and guest today, a fellow Canadian. Dr. Mia Biondi is an assistant professor and nurse practitioner program coordinator from the School of Nursing, York University, Canada. Director of Implementation Viral Hepatitis Care Network and University Health Network, Toronto, Canada. Mia has a PhD in microbiology and immunology. As a registered nurse and nurse practitioner, Mia has practiced in 4 models of primary care in Ontario. In 2017, she established focused practices in urban street outreach and rural and remote communities across Ontario, specializing in HIV prevention and hepatitis B and hepatitis C. Mia is an assistant professor at York University and the director of implementation at the Viral Hepatitis Care Network. I think in addition to looking forward to Mia's presentation today, I am very interested to know if people can tell the difference in our Canadian accents. Bonus points for guessing where we're from. Thank you. Welcome, Mia, please.
Well, thanks so much for having me. Thanks for the warm introduction. And thank you for coming in person and online. I'm really excited to share some of the work that we've been doing in the space around cis and trans women, as well as the pregnancy space. And just to start by saying, thanks to the organizers for inviting me and for everyone for hosting me this week. I've learned so much from you all. It means a lot that you took time out of your days. And I'm presenting any of our data, which this will not be all our data, but the data I'm presenting on behalf of my colleagues at the Viral Hepatitis Care Network. So these are my disclosures. And then these are my disclaimers. So I intend to speak about medications that are off-label, as you might be aware. There is not a place in the world in which treatment in pregnancy is on label. And sometimes I'm going to speak from my clinical practice. So if some things might be my opinions or maybe not guideline driven. And another disclaimer is, although I'm very proud to be Canadian, I just want to point out some slight differences in my week. So here's 6 a.m. This was the week before I left. These are 3 cars that are buried. So I'm going to the gym, 6:15. This was my 6:15 run here. 7:15, got a Zamboni, clearing a great rink, and sort of similarly, some type of Australian Zamboni. So I'll jump into the content, and I'm an educator in nursing, so I'm really all about the audience engagement, so I actually might ask you some questions during my talk. But I want to start by talking about a few papers that have been published around the call for a gender lens that is required in hepatitis C care. And I'm going to focus my talk specifically on hepatitis C, but I do some work in this space in hepatitis B and HIV PrEP, as was mentioned. So just a few key papers, and some of these folks are in the room, so I think that's really nice. That sort of ground us in terms of where we're at. And then some Canadian efforts. So there's a blueprint to inform the elimination of hepatitis C as a country. This was published a long time ago now, so it's 2019. There was some specific calls to consider things like pregnant populations and rural populations, but it wasn't really point blank in that way. And then in Canada, we've done what are called these roadmaps to eliminate hepatitis C. And so these are regional plans. And for Ontario and another province called Quebec, we actually have a provincial plan because these 2 provinces are very large and unique. And then in a lot of the other provinces, they're sort of grouped by like region, so west or east. So I'm going to speak to the Ontario roadmap, which we did call women and pregnant folks an emerging priority population. Just in terms of the epidemiology, I want to just point out a few key things. Many of you are probably familiar with the work of Homi Razi, but this is a really nice study that looked at some modeling predictions and looked at the fact that the prevalence is going up amongst women, and this is also in high-income countries, right? So you can attribute this to substance use, injection drug use, and then we can't forget about reinfection, which is, I think, similarly in Canada and Australia, very, very important. When we think about the global prevalence among pregnant folks, so if you thought about it this way, a global prevalence of 1.8 might not seem that high, right? But you're going to see that similar high prevalence amongst pregnant folks who use drugs. And then, of course, by region and by country, thinking about the endemicity, right? So just to point out, and I'll talk about children later, but hepatitis C from a vertical transmission perspective continues to be the #1 reason for pediatric transmission, not the use of contaminated, medical equipment and things like that you might hypothesize. Our Canadian data in this space is a little bit old, and so there's a group called the BC Testers Cohort. This is in our province of British Columbia, that probably have some of the more rigorous data in our country, and then maybe the most up-to-date data that really show this trend that amongst younger folks, women have a higher prevalence than men, right? So this is not typical because men typically have higher injection drug use rates and so on and so forth. But this was the first study to really highlight this. And I think it did give us that lens to be able to include this in the roadmap. And then I just wanted to point out a systematic review that's looked at 52 high-income countries and 14 low and middle-income countries where women are more likely across the globe to acquire hepatitis C at a younger age. Does that make sense? So what could we be doing about this? So the obvious, most important thing, the priority, should be preconception, screening, linkage to care, treatment, and cure, right? Seems pretty obvious. I think in a place like this where there's a lot of testing, it seems possible. In a lot of places, it's not happened. And that's irrespective of what I'll talk about universal screening and pregnancy, right? So people having multiple pregnancies. There's obviously a lot of structural and geographical barriers that apply specifically to women. And then I'm going to share some data around reinfection rates that are higher among cis women, and that late stage presentation in Canada among certain groups of women is actually quite high. There's, of course, intersectionality amongst all these populations, and I have a figure to show that. And we're thinking about doing this from a systematic review or concept analysis, I'm not sure, but really there's not those comprehensive models for women. There's a lot of microelimination projects, a lot of published work, some work that's not published but has been in abstracts and presented at conferences, but there's really not inclusive models that speak to a gender focus. I'm also going to share some data about pregnancy, but one thing that we learned through our cascade of care work using admin data is that the pregnant population actually has a higher planned termination rate when they have hepatitis C. And I would just want to mention that in terms of our prenatal work, this is actually all advised by a community of practice, which includes women who have used drugs, women with hep C, women who have hep C in pregnancy, women who care for women who use drugs, and so on and so forth. We've had an Indigenous doula. So we get a lot of different perspectives. And the thinking there is that people aren't in a space to have a child, and they know they don't want this child. And so they terminate the pregnancy. Some people might think that that might make sense to link the person to care at that time, but actually doesn't make sense according to our advisory committee. People aren't ready to be linked to care at that time. We've also looked at a concept analysis to think about stigma and women. And what we did here, and this is really important, is we did not include studies that had data that we had to separate, right? So if it wasn't clear that this data was around men and this data was around women, it wasn't included in the concept analysis. And that's the whole point of the call, right? It's not about comparisons. It's about having studies that are independently assessing different pieces around women. So this was looking at stigma amongst women. In a concept analysis, this is Rogers evolutionary concept analysis, we have things like attributes, antecedents, and consequences. And I think one of the most interesting and maybe surprising parts of the study was that showed that not only does stigma impact health-seeking behavior for the individual, but it really impacts healthcare seeking behavior for the child and the family, right? So this is not good when we think about a population who might already not be engaging in primary care, sort of for those routine vaccination, well baby checks, that we'd like to be on time because they're important from a public health perspective and from a person perspective. But the stigma piece is quite true and quite real. This is also done by a group in Ottawa. So Ottawa is also in our province of Ontario. This was work led by, some of you might know him, Curtis Cooper. And they did a qualitative study amongst 15 women living in Ottawa. And I think some things that we might not think about as sort of top of mind is disclosure pieces around wanting to have children in terms of disclosing to the partner, right? So we know now that, there's not a whole lot we can do unless we're treating in pregnancy, which we will discuss, but really this part about holding off on having children, not wanting to disclose to the partner and waiting to have children until after cure. But then all these pieces that you can see here, which is still very relevant, right? Like scared, worried about health, shocked, frustrated, shame. So just to highlight some of those things that we could attach to stigma. I just want to share one of our quality improvement projects that was amongst a residential drug treatment facility. We actually don't call it drug treatment, but I've adopted this from INSU and from the work in this group. This is called like a residential clinic. And so people are engaged in OAT and it's completely trauma informed and they can't have their cell phone. So they really want to be there. They're actually screened for 6 months prior to coming. They can use any substance, including cannabis. They prioritize folks who are pregnant and they prioritize folks who are being trafficked actively or at risk of being trafficked. So sometimes people do leave. They're often those folks in those situations that are maybe not as prepared to be there as some other folks, because it's a big deal to not have your cell phone for 5 weeks, right? But the whole point is to really engage in this trauma counseling and trauma-informed care. So when you do a bingo and have candy, and you all know this very well, and people are bored, it's a hit, right? So bingo, candy, look at some of the myths that people have told them that continue to press on. And we started this program in 2019. OAT docs still tell people they're not eligible for treatment. They're not eligible for treatment if they still can continue to use drugs and so on and so forth. This was actually going pretty well. So just offering point of care antibody testing with follow-up dried blood spot testing. But we were losing some folks who left early or they actually were pregnant. And so we didn't treat them at the time. So we did this quality improvement project to try to engage just those small number of folks. And you can see the number who are positive is overall generally small. But we were able to get this up to 100% after looking at our contact tracing form. I usually use the example of I've treated somebody through their grandmother. So we sometimes are treating people who we've never spoken to, right? Their family members are supporting the facilitation of them going to the lab. We're getting the labs. We're passing the messages back and forth. And this is a part of my practice in terms of models of care that I don't feel like I need to speak to everybody as the prescriber, whether it's an RPN, I'm speaking to the family member, an RN. We try to be as flexible as possible. The last piece of data I'll share is this large administrative database that's actually collected through hepatology centers across the country of Canada. And this is through our group called CanHepC. And again, focus specifically on trans and cis women. And we also looked at trans men. We're trying to get this published and it's been tough. So if you have a journal recommendation, I'll take it because the reviewers typically say these numbers are very low in terms of trans folks, but these are some of the higher numbers in terms of published data that are available. And when we talk to our community practice, who includes trans folks, they say it's of the utmost importance that we continue to try to publish this. So we're really trying. But women as a cohort, some interesting things we found are fibrosis scores are generally lower. The alcohol use is generally quite low. So when we think about rapid treatment starts and we think about women, these might be things that come into play. And then there are groups who are more likely to have cirrhosis, such as those who immigrated some time ago and are usually not linked to care in a very timely way. Folks who have been unemployed, you can see they're also more likely to be cirrhotic and things like that. The sad and tragic part of this is that many women were not engaged in OAT. And so I think that's a good highlight for public health perspective. I just want to share one study, which is not my study, but is led by someone named Alexander King, who leads a lot of the work in Canada from our CanHepC network. And this was a qualitative study because there's been a shift, right, around looking at aggregated data amongst Indigenous communities, talking about risks, and we tend not to do that, talking about comparisons, and we tend not to do that, right? So really thinking about some qualitative findings. And 3 themes emerged from this work: connection, disconnection, and reconnection. I'm going to give you a moment just to read them, if that's okay. Now I'm going to be an educator. I have chocolate. What stands out to you, or what might you take in terms of applying it to the local context? Anyone brave enough? Yeah, Becca.
I think the strong message that I'm seeing here is that with peer support role, how crucial it is to have that, like that idea of partnership and standing together, especially in the reconnect and all of those, that when we're beside each other, having the experience and supporting each other is
Another thing that comes up in this work, so well said. Another thing that comes up in this work is that training people, right? Training people from community. So thinking about, it doesn't matter if people are nurses or it's great if they are. And certainly we're trying to prioritize the training of Indigenous nurses in Hep C, but really that peer support, like you say, training people up so that they really feel comfortable to go out and speak about it. Thanks so much for answering the question. So I'll flip to speaking about perinatal HCV now as the focus of the rest of my talk, including pediatrics. And just to be really clear on the language. So perinatal means preconception, right? Includes intrapartum, or what people sometimes say as prenatal, and afterbirth. So that's postpartum, and it also includes the infant piece. Whereas prenatal, antenatal care, again, it's that conception to sort of that labor and delivery. So just in terms of language. And maybe someone can educate me on midwives in Australia, but in Ontario, 25% of all prenatal care is provided by midwives. So it's quite a lot. I don't know what it is here, but they haven't been so enmeshed in our work on hepatitis C elimination as of this time. And they tend to care for people who have no status. So they would prioritize folks with no status. So that would be really important when thinking about endemic HCV. They also tend to see a lot of people who have the resources and access to go online. So it's quite a divide in terms of who midwives care for. I also want to mention that I tend to say like pregnant folks or pregnant individuals, and this will shock you. This is from the NIH before the NIH was basically torn down. But I just want to sort of reiterate this use around that not saying pregnant women does not exclude people. Rather, saying pregnant individuals or saying pregnant persons tends to open up the umbrella so everyone can be included. The WHO still unfortunately uses the term mother-to-child transmission, which of course puts the blame on the mother, right? So that person, that's the transmission. So I'll tend to use the word vertical transmission. So again, speaking to the Canadian context, you might be shocked in a universal healthcare system that prenatal care is actually quite poor. So this is probably one of the best indicators in terms of looking at an optimally timed first trimester ultrasound. And you can see it varies quite a bit per province, and really no one's doing great. In Ontario, 40% of pregnant patients get linked to prenatal care through the emergency room. Isn't that wild? So the important part about pregnancy is you have to go to the healthcare provider a lot, right? Like you might not be well, you might have regular visits. You need a consistent, whether it's midwife, primary care provider, OB-GYN, whatever it is. But if you start this journey in the emergency room, you're probably not starting it early, right? Maybe you are, maybe you're not. I have some data on that in terms of hepatitis C, but it really impacts the ability to seek care. In terms of the perinatal space, I want to highlight 6 kind of updates in terms of this work, in terms of this space that have been driven by some work here in Australia, actually, and also some work in North America. So as I mentioned, rates are increasing preconception amongst women, and treatment uptake is low, right? Reinfection is high. Universal prenatal screening is now offered in Canada. It's also recommended by EASL, ASLD. It's universal screening here. And, it's pretty widely accepted now. There is evidence to recommend case-by-case decision-making for HCV treatment. And I'm going to go into all of these with some data. Children with a screening indication are not being screened. I have not seen a study that showed children are being adequately screened anywhere in the world. I'm going to share some data from US and Canada. Children as young as 3 can be treated, at least in Canada, by one of 2 pangenotypic drugs. In the US, it's both pangenotypic drugs, and you'd have to tell me what it is here in terms of on-label use for pediatric treatment of HCV. This is an urgent priority because children get fibrosis and cirrhosis, right? And then due to poor antibody screening uptake, ASLD, CDC now recommend an earlier screening by HCV RNA at 2 to 6 months. So just by way of show of hands, do we know this stuff? Is this new? Helpful? So I want to share with you our guidance from Canada. And one thing we wanted to do before getting the guidance, because we knew it was coming for 5 or 6 years, actually, it's actually published in 2025, but was rather quite old in terms of the evidence, was to look at the provincial prevalence. So provincial prevalence really matters if you're going to do universal screening. And that was always the argument as to why screen in pregnancy if you can't intervene, right? And if prevalence is going to be low. So just by way of a comparison, HIV is up here, right? Getting to 0, no child born with HIV. These are super important in high-income countries, and they are always prioritized. Our HIV prevalence is 10-fold lower than both our hepatitis B and hepatitis C prevalence, but we got to get to 0 with HIV, right? So it's just to put in context, the prioritization of resources. In BC, it's a bit lower. Ontario, it's similar to a Hep B prevalence. In our province called Saskatchewan, it's quite high, but they've actually had universal screening since 2003, so a very long time. They recognize their high prevalence early. And in Alberta, it's a bit lower. One thing that happened with our guidelines, which is not ideal, is that it clearly says, do not treat in pregnancy. And remember, I'm a primary care provider, so I read guidelines all the time in areas that I don't know anything about. Cardiology is my least favorite area. And so, you take these things at face value, right? It's a guideline committee, you do what they say, so on and so forth. And so this is problematic because the data is out of date and we have some other recommendations that are maybe a little bit better. But when we think about screening, and when we think about some of the data that has come out since universal screening, and I'd be curious again to hear what it is here, it's actually not been great. So the US adopted it in 2018 by 2 guidelines, and then ACOG, which is their obstetrical society, endorsed it in 2021. Now, what we hear from our American colleagues is until your obstetrical society endorses it, it's not real, right? So if you look at some of the data that came out of the US, you really only see incremental increases, like not even up to 50% before that ACOG guidance, right? And then some newer data from the US, that's the data on the right-hand side of your screen, followed it a little bit further. So sort of like that just post ACOG guidance. And you see a little bit of a blip, and we're still waiting to see what happens moving forward. But basically, they were doing with a universal screening recommendation what we were already doing, because we were already screening somewhere between 20 and 50% of all of our pregnant folks. I wanted to share with you a study that we did there because even with universal screening, so this was a quality assurance project that we did prior to the guideline change. We did a universal screening 1 year in a high volume hospital that served quite a diversity of people in a place called London, Ontario. So it was urban, but it was also quite rural and quite northern. And there were 32 positives, but the breakdown is really important. 66% of those positives were at 36 weeks plus, right? So when we start to talk about universal screening and treatment, we're going to miss possibly that window to treat and get people to an undetectable viral load by labor and delivery. We also went back to do rounds with this work, and we actually chatted with OBs who had these positives through the universal screening program. And the other really important part to consider is that most of them just flipped it back to primary care. So antibody positive, no reflex test for HCV RNA, back to primary care, deal with it later, right? A couple of people were referred to infectious diseases during pregnancy because that was the typical flow in that city. And again, lost to follow-up, not treated, postpartum, so on and so forth. I think this is really interesting. This is a US study that looks at physician-level determinants around adopting universal screening. And I think this is kind of random, that if you are a member of the obstetrical society newsletter, that you got this newsletter, you are more likely to start screening. I guess it makes sense, right? You have this flush of information. Think about how many things they get in terms of new guidelines, new practice, so on and so forth. So I thought that was really interesting. And of course, those with higher knowledge were more likely to implement the guideline. So why treat in pregnancy? Again, I'll go through the data. Treatment likely reduces, if not eliminates, vertical transmission and ensures that there's no transmission in the next pregnancy, right? Women are not engaged in treatment postpartum. I'm going to share some data from our work, but there's so many studies in the US that look at hospital level, systems level. There's a beautiful study by Medicaid that shows that people are not treated postpartum. Women want to be treated in pregnancy. And then 2 guidelines recommend case-by-case decision-making, right? So it really behooves us as clinicians to at least offer treatment in pregnancy. Pregnancy studies have shown promise in terms of safety and efficacy, and I'll share some of that data. And then there's multiple people in this room who are on a rapid evidence review to identify sort of all of those cases that we could actually accumulate to think about safety in pregnancy. And then women are actually being offered this as a standard of care now. And so we're looking at discussions, and we've done some qualitative work on facilitators and barriers as to why women choose or don't choose treatment in pregnancy. So this was a really nice study using administrative health data from Ontario, and it was only people with an HCV RNA in the pregnancy. That's really important because that really limits the number of people that are in the cohort, and looked at vertical transmission in terms of viral load. We're trying to do something similar and sort of validate it and see how true it is. But I think the point here is that decreasing viral load, so maybe getting it to less than, 3-ish logs, really eliminates the risk of transmission at labor and delivery. There are some studies that maybe show that transmission can occur in utero. It's most likely at labor and delivery where there's a lot of blood and fluids, right? So I think that's really powerful when we start to think about how do we convince OBs, primary care, et cetera, to start thinking about treating in pregnancy. And it doesn't have to be perfect. You don't have to be done your treatment by labor and delivery, right? You need a couple of weeks to knock the viral load down. This study also showed that pediatric screening was abysmal. It was 29% of people that had a diagnosis in the pregnancy. That's awful, right? Like the diagnosis is right there. So again, this comes back to primary care. This comes back to a lack of universal sort of reminders, triggers, whatever you want to call them. We think this is pretty powerful because it's probably one of the bigger cohorts. So this is, again, work from Ontario that was led by someone many of you know, Dr. Andrew Mundlewitz, who finished this work just last year. A pretty huge database where we identified pregnancies. So we didn't identify live and stillbirths, which is usually where people start. They kind of work backwards. We identified pregnancies. So includes that 30% of people who actually choose to terminate. Does that make sense? So it's a much different study. And this took a lot of time to identify pregnancies. I think for me, there's lots of great data in this paper, but for me, one of the most important things is if we think about the first pregnancy in the cohort as the index, treatment should happen after. Right? Pregnancy, diagnosis, treatment should happen in between those pregnancies, right? But as you can see, even though overall, because it's a 20-year cohort, many people are treated, so 52 people are ever treated, very few people are treated before the next pregnancy, right? So like that 2-year window, that 3-year window. And in fact, people have up to 5 pregnancies prior to being treated. I think the acceptability data is quite convincing. There's been a study from the US that showed that women wanted to reduce the chance of vertical transmission for the child, and that was their main reason for choosing. And then 20% said it didn't matter to them, that they were doing it for their own health. And it's been replicated in Egypt, Ukraine, Pakistan. We're doing it in Ontario, but I think it's pretty clean. And then there's been a qualitative study that was done during the phase 1 soft lead trial, where they looked at 9 participants and did 18 interviews. And I'll just give you a moment to sort of read those themes. Makes sense, right? It's probably what you would expect. I'm going to go through 2 observational studies because now we're getting into the, what do the clinicians want to know, right? How do we convince them? So there's been a pretty nice study done by Tatiana Kushner. She's in the US, and she did this really early. She did this in 2017. She followed 23 people. She mostly chose soft lead or soft vel and then did GLP-1 postpartum. And so that's really one of the early studies around sort of safety and outcomes. And then there's also a largish study that was done in India, also used soft lead, showed 100% SVR and all that good stuff, But one thing I want to point out here, which I think is fascinating, is that you actually cannot test infants early. You cannot test infants at 4 weeks because they saw that there was something there, whether they cleared or there was residual, whatever it was, that those infants then became negative. I thought that was interesting. There's also something called the TIP-C registry, and there's 2 Australian cases in the TIP-C. So if you were part of that, that's amazing. But if you're not a part of that or you're not aware of it, they have a QR code. And if you can encourage your colleagues to contribute to this database, it's really helpful. As you know, registries don't tend to have impact until you have 2,000, 3,000, right? To really look at safety signals. So they're really accumulating this data. This was presented at AASLD, which really shows that of the 37 cases, there were no adverse outcomes that could be attributed to exposure to medication in pregnancy. This is both those who are treated later in pregnancy and those who didn't terminate when they were pregnant on treatment. Does that make sense? Those cases are far more few in between, and the guidance on that is actually really unclear. I think it's very clear you don't terminate the pregnancy, but whether or not you should stop treatment when people become pregnant on treatment is less clear, and there's no guidance around it. We're really proud to be a part of this trial called STORK. So STORK is safety and efficacy of Soft-Val in pregnancy in the 2nd and 3rd trimester of pregnancy. So we have 3 Canadian sites, but we only recruited at 2. The target was 100 people, but we're going to end up terminating early and landing on 85 to 90 people, which is not bad, but it's been a long time and we really need to get the data out. This was also presented at AASLD. And so you can see that everyone who completes treatment is cured. Shocking, right? If you complete treatment, you're cured. The people who did not achieve SVR missed 20 doses and 28 doses of Soft-Val. And I don't have the timing off the top of my head, but you can imagine that if you miss close to a month, you might not cure. There have been no severe adverse events on the pregnant person side or the pediatric side that can be contributed to Soft-Val. But there's a ton of events, right? Because pregnant people have lots of SAEs and children end up in the NICU for neonatal withdrawal. Does that make sense? So one thing that we're trying to push in terms of knowledge translation with some of this data is you have to understand the baseline of all of these events. You have to understand that when people who use drugs have a child, their child might end up in the NICU with neonatal withdrawal, right? It's a severe adverse event, but it's not attributed to the medication. And unfortunately at AASLD, there was a presentation on some of the pharmacovigilance data from Gilead, and it's clearly said at the end of the conference, do not treat in pregnancy, which is really bad because they misinterpreted the fact that these baseline impacts are really crucial, right? Baseline preterm birth, baseline spontaneous loss of pregnancy. We're doing a little bit of work in this space around real-world adoption. So we have already seen that many clinicians are offering this as per the guidelines. So some case-by-case decision-making in terms of guidance. These are mostly ID folks and hepatology folks, but I think we're seeing more and more that primary care is doing it. So we thought, like, if people are doing it, we must gather data, right? Interestingly, we've recruited the same number of people for this study in 1 year than we recruited for STORK in 4 years, right? So the format of this study is consent is after the person has discussed treatment in pregnancy with their provider. Does that make sense? So they've decided to go with it or they've decided not to go with it, and then we consent them for the observational study. Does that make sense? So some of the outcomes are pediatric follow-up up to 6 months. We really shorten that from STORK because STORK is a year and it's far too long. We use the well baby records. We're doing HCV RNA at 2 and 6 months. We're also doing DBS. It's interesting. So a heel poke based DBS. We won't get the numbers in terms of like a validation study, but we thought we should try to do it. And then we're also doing Gene Expert, again, sort of like as a mini validation for what we can get. We're doing qualitative interviews. So I think this is actually one of the most valuable pieces of this study. We're interviewing people after they make their decision. Like, why did you choose or not choose treatment? And then postpartum, how do you feel about your decision? Did you get linked to care ultimately? And so on and so forth. Sam, I really like how validating you are. You're a great front row audience member. We have a few results. 7 sites in BC and Ontario in this 1 year. So 7 sites and 7 participants, not evenly distributed. Only 1 person has declined treatment so far. And there's only 1 person who didn't know about their diagnosis until this screening in pregnancy. So I think ultimately we've seen huge impact of the universal screening and pregnancy guidelines. Like we get far more referrals for people that had no idea they had Hep C, typically from endemic countries. But that was one question here, like how many people didn't know their diagnosis? Some facilitators were protecting the infant and having positive relationships with the following people: the provider, their family members, and their partners. These were hugely influential in whether or not people chose treatment or not. And there's a piece around online searching. So people did really rely on online searching and what data and evidence was there. And so it's nice because we're working with a group called CTN Plus in Canada to create these 1-page fact sheets on different medications of treatment in pregnancy, so that when people search, they'll get this nice fact sheet that talks about treatment in pregnancy. Some barriers included stigma and some competing stigma, I guess I'll say, but also competing information from different type of providers they had. So they might have hepatology ID who they're talking to about treatment in pregnancy, but then they have their OAT provider who's saying, no, it's not safe in pregnancy. And they have their primary care provider who's saying, I don't know anything about this, right? So it's just a lot of information and people found it really difficult to sort of sort through that information. There's also a time limit, right? Like we discussed, if you're going to choose treatment in pregnancy, you ideally want to have at least 4 weeks to get to undetectable by labor and delivery. I thought this was really nice in terms of like summarizing the whole thing. There's no correct choice, right? You balance this medication, which has some safety data, but not years and decades, versus potential vertical transmission. And I just want to quickly update you on vertical transmission, that it was classically always said 5%, 5%, 5%. And now systematic reviews are saying more like 10%. So the vertical transmission piece has changed a little bit in terms of what we might understand. This is going to be my last slide on treatment in pregnancy, I think. And so I wanted to share this brand new decision-making tool that came out from a US group so that people can actually navigate this decision. Has anyone seen those contraception tools where you're like navigating what's the right contraception for me? And do I want an insertable, in situ, oral, et cetera? It's kind of like that, like goes through the different sort of cases and brings you into an algorithm. But not everybody's going to choose treatment in pregnancy, right? So we know postpartum care is very poor. Linkage to care is very poor. So we were a part of a community of practice that looked at what are some of the things, and hopefully you can take this in your work, to support treatment postpartum. I just want to point out that EASL, unfortunately, recommended that treatment in pregnancy be done by specialists. And that's not great, right? Because that takes us back like 10 years where regular treatment was also done by specialists. So we need to think about decentralization for sure, but we also need to think about, if we're going to be inclusive and talk about treatment in pregnancy, it's really got to be done by anyone who can do it, right? So if you provide prenatal care, which for us falls amongst a lot of primary care providers, and you work in a community health center where you see folks with Hep C, you're good. You can do this, right? So this was an unfortunate recommendation by EASL. I'm going to spend the last 5 minutes just talking about pediatric screening. I have another chocolate. What do you think pediatric screening uptake is in Australia amongst folks that are, let's say, positive before pregnancy or diagnosed during? Do you think it's less than our abysmal 30-ish%? Yeah. So we have now looked at this from that cohort, that was the pregnancy cohort, and now we're looking at the infant side of that cohort because these cohorts are linked. Again, this is done by Andrew Mundlewitz, and we looked at ever testing, and we also looked at patterns of practice. So I don't have that data here, but we looked at like, was the timing for the test correct? So I mentioned you should not do an HCV RNA at 1 month, right? That's pretty clear. What we don't know is if we could do an antibody at 2 months, and if it's negative, does it stay negative? Probably, right? If it's positive, they still might clear maternal antibody transfer, all that stuff. But we're really just looking at testing uptake overall. So ever antibody tested, ever RNA tested, And really, this actually landed exactly in the same place as the group who had a diagnosis in pregnancy, but this was the group diagnosed before or during. It's still terrible. It's still about 30%, 40%. We looked at predictors, or Andrew looked at predictors, and in terms of probability, so the probability of being screened by 24 months was, again, that 30%. And some predictors included an HIV diagnosis, which makes sense, right? Typically, people who are engaged in HIV care, there's really thinking about the family. You're thinking about the partner, children, so on and so forth. That RNA positive in pregnancy was a predictor. A low birth weight was a predictor, and a pediatrician or GP visit. One of the problematic pieces around our data is that it doesn't actually capture community health center data, and community health centers are typically where people are seen. Okay, so why is it so crucial to test and treat as young as 3? I want to share some really amazing data from Poland, where they looked at 135 children. This is a lot. This is a big cohort, right? We never get these kind of cohorts. The mean age was 10.4, and 93% of these children had acquired this vertically. Probably the other pieces was through medical issues, right? They were all treated in a DAA era. 1 year after curative treatment, 7% had fibrosis. Their mean age is 10, and 2% had cirrhosis. Can you imagine like a completely preventable situation in the DAA era and 2% having cirrhosis? We don't know exactly what it looks like in Ontario because we don't have the follow-up data and we don't have a cohort, but we think there's probably 1,000 children that are not identified. And we have a little data on what pediatricians are doing. I'm showing it here, that in the time of this ability to treat pediatric Hep C, there's been 31 prescriptions in our province. 1,000 kids, 31 prescriptions, right? This is just a figure to explain sort of that idea of testing really early. I do want to mention one crucial study that was done in the US that perfectly showed the longer you wait to screen, the lower screening is, right? So they tied these to well child visits, 2 months, 6 months, 1 year, 18 months, which was the antibody guidance. And it just goes, right? You end up with this 20% at that 18 months. So the point is screen early, treat early. I'm going to end by sharing a case. This is a case that was published in a paper with permission, and it uses a pseudonym. Marissa is a 35-year-old with a remote history of substance use and incarceration. She connects with you 1 month postpartum, requesting HCV treatment. This is in a low-barrier self-referral program, as she has known she was positive for a decade. She is concerned that she has transmitted HCV to her infant and blames herself for not being treated preconception, but states that she had competing priorities, like she was working and she had a family and she was not using substances at that time, right? She had, like all of us, competing priorities. She initiates treatment and asks about testing her child. You explain that children can be tested, right? Because we're doing this new thing, as early as 2 months of age, and it can determine whether or not they have active HCV infection. Marissa requests an HCV RNA for her child, and the result is negative. Although relieved, Marissa would like to ensure that the child is also antibody negative. This actually goes against the CDC guidance. As such, you book an appointment for a test at 18 months, and in the meantime, Marissa is treated and cured. Marissa's main concern is that although she knew her child did not have active infection, she wanted to know their antibody status and test was negative. She feared that if by some chance they were tested in the future, they would then experience the same stigma in healthcare with a surprise antibody test, right, that she had experienced so many times. The 18-month antibody test is negative, and although Marissa felt guilty about not being treated preconception, she was relieved, and the child will not have to live with the stigma of hepatitis C. So these are my take-homes. Oh, I'm never on time, but I'm kind of on time. These are my take-homes. Screening and treatment preconception. You're doing this really well here. This is super important. Screening all adults is something we're looking at in Canada from a public health perspective. The US has already done it. The median age of our infections among women is 30, right? So we think most people acquired Hep C prior to any of the pregnancies, even if we're not capturing it in the admin data. We'll in Canada have to look at what our uptake is on universal screening. I think it's going to be pretty good because we're such rule followers. We love a guideline, but we really need help from our public health labs because they don't want to do it. They said they can't manage the volume. In a place like Ontario, we're going from 30,000 tests a year in pregnancy to 140,000 tests in pregnancy. It's huge. They have a fixed budget, right? It's not up to them. So we're going to have to do some work there. Some provinces have already adopted it and added it to a prenatal requisition. I hope I've convinced you about treatment in pregnancy. It should at least be offered with a good amount of discussion that's based on the evidence. And yes, right now our evidence is soft lead, which I assume nobody uses, or soft bell, right? These sofosbuvir-related regimens. When does transmission occur? We'll have to figure this out. If we start treating a lot of people for hepatitis C in pregnancy and children still acquire hep C in those early years, we'll have to figure out what's going on there. Those might be some cases of in utero transmission, right? I just have a quote here that, again, this provider influence is so massive. Like my physician said, treatment is not approved in pregnancy and therefore I can't do it, right? So we have to do this like sort of KT around this work. You might ask me about breastfeeding. There's a tiny bit of data. It's PK data. It basically shows it's less than 10% of the drug concentration in breast milk. And then we're thinking we really need to incorporate reminders into like our well child visits. We already have reminders for hepatitis B. So was this parent hepatitis B positive? Did you do birth dose and so on and so forth? And we think this is really important for hepatitis C. Thank you again for being here, and I'm happy to take any questions. But just to mention that there was advisory committees, trainees, investigators, and many people who contributed to this work. Thank you. They said, if you go first, you get the last chocolate.
Aw, I always go first. You should know better than that. I actually have two, so fantastic talk. Thanks so much, Mia. It's been fun having you out here as well. So I have two questions. My first question is, why do you think Stork was so slow to recruit? Like, what was it? What did you guys find at your site? Was it, yeah.
Yeah. In Canada, I believe it was slow to recruit because we weren't universal screening from the beginning. It started in 2022. So that kind of coincided right with the US sites having their universal screening guidance. But then it also really plays into like, where are people living? So I think for us in Toronto, we had referrals from maybe 1 hour away. People just weren't willing to come, right? Like clinical trials, you have to gotta come in person. You have to come every 4 weeks. People basically said no. One person, this was super interesting, they were pregnant twice in our study. So they were referred to our site first. They said no. They were pregnant again later. This is their 6th child with hepatitis C. They went to one of our partner sites. They said yes.
Yeah.
I think they like that doctor better. So, I mean, in the US, the sites were quite varied. Many sites were co-localized addiction and pregnancy care. So they had better uptake. But I think it's always like when you do a clinical trial, you have so many pieces around in-person visits, blood work. I think the honorariums are kind of garbage in terms of what we're being offered. And to think it's not enough of an incentive. Because our observational study, super low barrier, lots of phone-based care, and people are more happy to be part of it.
Mm. So my second question is, it's really interesting when I spoke to WHO, said, why is triple elimination, HIV, Hep B, and syphilis, and why is hepatitis C not included? The response I got back was because we don't have data on efficacy of treatment for hepatitis C in this setting. So now that we're going to have this, I'm just sort of curious as to your thoughts about, do you think that we'll actually move towards quad elimination? Yeah.
I do think that when Stork is published, which it's a bit far away, right? We're just stopped enrolling, so it's a 1.5 years from publication. It's really long. I do think WHO, and those conversations are already happening with WHO around the Stork data and what will happen in publication. I think one challenge will be almost definitely most countries will not put it on label. And so when things don't go on label, like they won't seek FDA, for example. I don't believe they're going to seek Health Canada approval for on-label use of treatment in pregnancy. We get caught up with reimbursement issues. So in a place like the US, that's problematic, right? Because it's not on label, that impacts reimbursement. But I think in low and middle income countries, there's actually way more appetite for this. Like we're doing some work in Ghana around Hep B and midwives, and we're saying like, should we just incorporate hepatitis C? And they're like, of course. you're going to train people on Hep B, train people on Hep C, right? Where midwives are already doing so much HIV care. I don't know if that answers your question.
Yeah, absolutely. Thank you so much.
Is there any other questions from the floor? Yeah, there's just one question from the floor.
Hi, Mia. Great. You mentioned around starting treatment kind of early, which is, of course, is great. But is there any data, on late starts, like really perinatal? Because kind of extrapolating from HIV, 4 hours of zidovudine decreases like mother-child transmission to less than 1%. Is it just getting any DAAs into body that's enough versus actually having to get to viral suppression?
Yeah, of course, I don't know because there's no rigorous data, right? Like, so people could be up to 30 weeks in stork, so they have to be between 20 and 30 weeks for their first dose. And part of how we recruited, maybe Jason, this partially answers your question, is when people were not eligible for stork, we asked them if they want to be in our observational study, right? So that's why we want to do this study, because we want to capture some of these pieces that are so difficult to capture. I don't believe it'll be a few hours before. I think we'll have to borrow what we know about current getting to undetectable. That's probably our best surrogate, because in stork, we do have like the HCV RNA at labor and delivery. The investigators on the team don't necessarily agree with me, but I think this is one of the most powerful pieces of data, right? Like, what's the HCV RNA at labor and delivery? Because people won't have finished, right? If you enroll at 30 and you deliver at 36, you're only 6 weeks on treatment. Make sense? I think it's about 4 weeks.
Yeah, but is it just having DAAs in the mother's blood that'll prevent transmission?
We don't know. I mean, I think ideally you try to set someone up to get to undetectable, because you also don't want to have people who have a vertical transmission event, which then can sort of start to bias the discussions around. So I think if you're going to start somebody like the day of, which you could for sure, you might say like, this might have no impact, but hey, at least we're getting you on treatment, and so on and so forth. I would also say that time around labor and delivery is one of the trickiest parts of stork. People miss their drugs a lot. So it's also something to consider. People might miss a whole week around labor and delivery. You ideally don't want that in the first 4 weeks. Does that make sense? Yeah.
Sorry, I'm just going to go to the question that was posed to you online. So, great talk. What is the update of syphilis testing in pregnant people in Canada? Any way to integrate with syphilis, hepatitis C testing more?
Oh my gosh, I have a slide on this. Okay, so syphilis testing is universal in pregnancy. So universal screening in pregnancy is chlamydia, gonorrhea, syphilis, HIV, Hep B, and now Hep C. Oh, yeah, please. And so one group, when they rolled out universal hepatitis C screening in pregnancy, actually they're wonderful. They're from Alberta. They're a small province, so they can do a lot. Their microbiologist called the primary care provider. This was amazing. But in the same study, they looked at syphilis co-infection, right? So we already do universal screening in pregnancy. There are challenges around getting access to penicillin for folks who might be underhoused, unhoused. There's cold chain issues, but this data I think is really compelling, right? Look at the co-infection between HCV and syphilis. So I don't know if I'm answering the question online, but I think it just really highlights, don't forget about syphilis. Yes, we already screened for it, but one thing that's happening in Canada, and again, curious to know what's happening in Australia, is not only are we incorporating HCV screening, but we're doing syphilis twice. So we're screening for syphilis in first trimester, and we're screening for syphilis in third trimester because we have many outbreaks of congenital syphilis.
Thank you. Any other questions from the floor? I just have a follow-up question for you, just because we're doing a little bit of research in this area in the Australia context, and I wanted to know what the sort of obstetrician support or appetite is for the treatment of hepatitis C in pregnancy in Canada.
Can I speak Canada and globally, maybe? Because I think it's really interesting to see, like, when you present at a liver meeting, when you present at an OB meeting, when you present at a fetal maternal medicine meeting, right? And so the US folks, I mean, The lead is an obstetrician. And then we have several maternal fetal medicine investigators on the team. So they're really pushing to all these conferences to present the stork data, right? It's safe in pregnancy, there's no adverse outcomes, and so on and so forth. I don't actually know if ACOG is going to ever pick it up. And I don't know if the Fetal Maternal Medicine Society of the US is going to pick it up. In Canada, I shared our unfortunate guideline, which is the infectious disease committee for our Society of Obstetricians. One of those folks is on our study team and 2 are not. And it's amazing how a group of 3 people, how 2 people can influence decisions. So I think it will take time. I think it's crucial though, right? Like in hepatitis B as an example, the fact that OBs really don't take on hepatitis B care and treatment in Canada, I mean, we've shown most people don't get their trimester antivirals, right? So if we're thinking about the same way for hepatitis C, I mean, I think it has to be there. But I just also want to say, we could also do more with primary care. We can't forget about primary care. Primary care is going to be the first point of contact if they have it.
Great. Any other questions at all? Okay, I just wanted to thank Mia very much for an interesting talk and thank everybody online for engaging as well. Thank Radha and Sam. Thank you. Thank you.